All right, everyone, welcome. Today, we're diving into a topic that, believe me, you'll be dealing with every single day of your medical careers: adverse drug effects. Now, this isn't just about scoring marks in your exams, okay? This is all about patient safety. Cello, let's begin.
Have you ever really thought about it? I mean, from a simple paracetamol to a heavy-duty cancer drug, they all have that super long list of warnings. But why? Well, it's because the exact same chemical that has the power to heal also has the power to harm. And understanding this delicate balance is exactly what we're going to explore today.
So here's our plan for this session. We'll start with the fundamentals, what these effects even are. Then we'll get into how to classify them, the predictable ones versus the really strange ones. We'll look at how we track them, and we'll wrap up with the most important part, how you can play it safe and actually prevent them from happening.
Okay, let's get into our first section. The main idea here, the absolute core principle, is that no drug is a magic bullet. Not a single one. Every time you write a prescription, it's a calculated decision. You're weighing the good it can do against the potential bad.
This right here is probably the first rule of pharmacology you should never, ever forget. The choice to use a drug is always a risk-benefit analysis. A very high-risk drug might be completely fine for treating a life-threatening cancer, right? But a drug with even a mild risk might be totally unacceptable for, say, a common cold. It's all about the context.
So first up, let's get our terms straight. We have adverse effect. Just think of this as the giant umbrella term. It covers literally everything you don't want to happen, from a tiny headache after taking a pill to a massive, life-threatening reaction. If it's a bad outcome from the drug, it fits under this umbrella. Simple. Okay, now let's zoom in a little. An adverse drug reaction, or ADR, is way more specific. The two magic phrases to remember here are suspected to be due to a drug and at normal doses. This is so important. It means we're not talking about someone taking too much medicine or a pharmacist making a mistake. We're talking about something going wrong even when the drug is used exactly as intended.
And finally, we have the adverse drug event, or ADE. Now, this casts the widest net possible. It's basically any bad medical thing that happens while a patient is taking a drug. So what's the key difference? We don't actually know if the drug caused it. It could just be a total coincidence. Maybe the patient would have had that problem anyway.
So you see, the crucial difference here is all about causality. With an ADR, we have a suspicion. We think the drug is the culprit. But with an ADE, we're just noting that something bad happened during the treatment. Let me give you an example. If a patient on blood pressure medicine falls and breaks their leg, that's an ADE. But if we suspect that the medicine made them dizzy, which caused the fall, we might then classify it as an ADR. And getting this distinction right is absolutely vital for reporting and for figuring out if a drug is truly safe.
Okay, so we've got the vocabulary down. But how do we organize this huge world of potential problems? Well, it's actually pretty simple. We split them into two main categories: the predictable ones and, well, the ones that are just plain bizarre. And this classification is the key to managing them.
Now this slide, it simplifies everything beautifully. Type A, think A for augmented. These reactions are the predictable ones. They're basically an extension of what the drug is supposed to do, just a bit too much of it. They're common, they're related to the dose, and you can often prevent them. It's like a known side road. But type B, B for bizarre, these are the wild cards. They're totally unpredictable. They have nothing to do with the drug's main job and everything to do with the patient's unique body chemistry. They're rare, not related to the dose, and usually much more serious. This is like a case of mistaken identity by the body's immune system.
All right, so we have our two main types, A and B. Now let's break it down even further. We're going to look at some specific types of complications and, very importantly, how we grade them based on how serious they are in the hospital.
So within those big type A and B buckets, we have more specific labels. Things like side effects and toxic effects are classic type A. They're predictable and based on how the drug works. But then you have drug allergies and idiosyncrasy, which is just a fancy way of saying a genetically determined weird reaction, and those fall squarely into that unpredictable type B category.
And look, this shows you the whole spectrum of what can happen. It's not enough to just know what happened. We have to know how bad it was. A minor reaction could be a simple rash. No big deal. A moderate one means we have to actually change the treatment plan. A severe reaction is a full-blown medical emergency. And well, a lethal one, that speaks for itself. This grading system is absolutely essential for good documentation and for making smart decisions on the fly.
Okay, so we know these reactions happen, but how do we learn about them? Especially the really rare, bizarre type B ones that never show up in the initial clinical trials. Well, this brings us to the super interesting field of pharmacovigilance, which is basically the essential detective work of medicine.
The World Health Organization defines it perfectly. You see, it's not just about collecting data, it's an active science of finding, evaluating, understanding, and ultimately preventing these bad outcomes. The entire goal is to make medicine safer for every single patient.
So how does all this detective work actually happen? Well, it's a continuous cycle. It starts with watching drugs after they're already on the market. Then, doctors like you report any reactions you suspect. All this data gets analyzed, and if a pattern pops up, drug alerts are sent out. And in really serious cases, this can lead to big changes on the medicine's label or even pulling the drug from the market completely. It's a living, breathing system that's all about protecting people.
Now, all of this leads us to our final, and honestly, our most critical section. Knowing all this theory is one thing, but applying it to prevent harm, that is what will make you a good doctor. This is about being proactive, not just reacting after something has already gone wrong.
All right, Bacho, pay very close attention here. This is your mental checklist for every single prescription you will ever write. Before your pen hits the paper, you ask yourself, 1. Is this drug even necessary? 2. Is the dose, the route, the frequency correct for this specific patient? 3. What is their history? Have they reacted badly to anything before? 4. What other medicines are they taking? 5. How exactly will this be given? And 6. What tests do I need to run to monitor them? These are not just suggestions. They are your absolute duty for patient safety.
And that's the hard truth of it all. As doctors, we can be smart, we can be careful, and we can prevent a huge number of these adverse effects. But we can never, ever get the risk down to zero. We can't eliminate it completely. And that's a crucial piece of humility that you have to carry with you throughout your entire career.
So, I'm going to leave you with this question to think about. A medicine's true worth isn't just in its power to cure, but also in our ability to wisely manage its power to cause harm. Navigating that incredibly fine line, that, my friends, is the art of medicine. And it will be your greatest and most humbling responsibility. Thank you.